All right, so we are back with another PCBH Corner, and I can't believe that this topic is one that we haven't done specifically.
Yeah.
I know that it's in a lot of our other videos or in different presentations that we've had, but it hasn't had its own topic for the PCBH Corner.
Yeah, I'm excited about it too, and I think we even teased it a little bit because we do have one video that's like number of visits, but it's related to number of visits within the patient, right? And
yes.
I think actually a lot of people tuned into that because like, oh, this is that one video about number of visits in a day. It's like, no, it's actually related to
And it's funny because that was our second video we did on number of visits.
I know.
So we keep on, I just kicked the camera. So I think that, we kept doing that. But when you do so many PCBH Corners, sometimes
Correct.
You forget which ones you've done.
And you start repeating them, Yeah, for sure.
So we are going to be talking about visits per day.
Okay.
How many visits should a BHC complete during a full clinical day? And just for the sake of generalities so that we can have a fluid conversation, we're going to imagine that it's an 8-hour clinical workday. So kind of thinking about approximately 8 to noon for a morning session. We sometimes in our organization call that a clinic,
right.
The morning clinic. And then the afternoon clinic, which would be somewhere around 1 o'clock till about 5 o'clock. And so that's what we'll be going on.
So we're talking about basically like an 8-hour day.
Yeah.
That is clinic. Yeah.
Yeah, 8-hour work day. And so if you are somebody that does 10 hours in your day, you might have to do a little bit of math.
There you go.
Or if you tend to work half days or whatnot. So in the literature, I think that things have evolved in PCBH. So if you go a couple of decades ago, there was very little billing, if any, related to PCBH. And there was very few BHCs just in general. So you might have had a system where there were a ton of medical providers, and the BHC was operating and doing these little snippets here and there. But now things have kind of changed a little bit, where you can bill for, almost every visit has some ability to be billed for in a system. Many systems have more than one behavioral health consultant. They are most organizations now are looking at that expense and revenue item.
For sure.
And they're looking to break even.
Correct.
And so that brings up a whole host of things about what is aspirational, what is historical, what is allows a budget to become budget neutral. And then taking this into consideration. So I'm just going to flat out ask you, how many visits do you think that a BHC should have in a day?
Yeah, and I think where my mind goes first is I'm really glad that you laid out some of the contextual factors already that is driving this conversation that we had asked a lot, like how many visits should a BHC? And so I think there's some things that we need to define, and then I think there's some other contextual factors that we need to go to, and I promise you we will actually say what we think the number should be at some point in this.
You think?
I think so. I think we'll get to some examples, some different things that we'll get to what a number actually should be. So the first thing is we need to be intentional about defining what a visit is. And I think that's an important thing, particularly when you start to talk about the revenue realities that are driving a lot of these conversations. And so if we can, for the rest of this conversation, whenever we say visit, we're saying a meaningful clinical encounter that's resulting in the vast, vast majority, we'll say 95% of them being billable encounters.
Because almost always they hit that threshold of 15 minutes and 30 seconds.
Correct, exactly. That you're hitting that, you're crushing that threshold of the time related for if you're gathering context and delivering intervention that is based on shared collaboration. Most visits are going to be that length of time. So if we can have that moving forward within this conversation of how many visits, we first need to define what a visit is. We just defined it, a meaningful clinical encounter, the 95% or more are billable. I think then the next thing that comes into a really important part of this is that, and let me know if you don't want to go down this rabbit hole because this might not be something you want to, is what percent of the time the BHC is in clinic throughout the week.
Oh.
Because I think that's a big thing when we start talking about visits per day.
I do think that we should go down that rabbit hole. And for those of you who might be wondering about what you had said about a meaningful clinical encounter, we, in our system, we don't worry about if there's a 12-minute visit, we push it through. We don't take that out of a clinician's number. And like you were saying, that if you are taught to do a contextual approach with shared decision making, almost always, it's going to hit that 15-minute and 30-second threshold, which is going to make it billable. So that is something we teach our BHCs to do what's best for the patient, and based on the time that you have, aiming to have a meaningful clinical encounter. I just had in my last clinic a 9-minute visit.
Yeah.
It was meaningful and it was a clinical encounter. And when we do our numbers, that's going to go into the number.
Correct.
But it isn't billable, but we're not going to worry about it. We're not going to go through, oh, here's Bridget's number, but we're going to remove that, because we don't want to incentivize our clinicians to do anything other than putting the patient first.
And to the point, as you said, like, we literally don't, now, if it ever became something that was like, oh my gosh, this BHC has had 120 visits and they only, 60 of them have been reimbursed, we might start having a conversation about that. But we literally don't even have those conversations with our team about like, hey, make sure this % of your visits are billable. It is literally just do what the patient needs in that moment.
And we're up to 20 plus BHCs, and we have not seen that. That has not been a problem over the course of the 9 years that we've worked there. Correct. So don't want to go down that rabbit hole. We want to stay on task. So that was my bad there. But I agree with you that we do want to go down the rabbit hole that visits per day should be impacted or influenced by the amount of time that their 1.0 is related to clinical.
And I think we have another video, I think, about this, about schedules and different things. So I don't think we need to go into it too much within. The only thing that I would say is that, Naftali had within his first book, what is it? The
Implementer's
Guide to PCBH. And we've seen this within our own clinic after we've adopted that model, is that if a clinician works 100% clinical versus a clinician that works 80%, they basically see the same amount of patients. So right. I do think if you're a director, and say you're a director, and I think this is another important part, because I don't think administrators are probably going to just be on board to give everybody like time out of clinic for paperwork and teaching and project time like we have within it, because it took a number of years to get built up to that sense. So I think just having in the back of your mind, so you don't have administrative support to reduce everybody's clinical FTE to like 80% and give 20% admin time, just to know that I would probably have a lesser number of expectations for visits per day if this clinician is working 100% clinical. I would probably even say if they're working 90% clinical, I would probably still have a lesser expectation of what I would traditionally have.
So you're saying that regardless of what the actual setup is or isn't with people in their organization, that if they're a director, they should keep it in mind.
Absolutely.
So based on whatever we say today, they're going to keep it in mind to if they're working 5 clinical days versus 4 clinical days, or 32 clinical hours versus 40 hours.
And it's not like we have a specific algorithm about, based on this lessening of FT clinical, this increase of productivity. I would just say if the person's in clinic, is scheduled to be in clinic less, their productivity should be higher.
Right.
In general.
Right.
Just because they have some reprieve for that. I think the other contextual factors that, again, we don't need to go into though, is like, is this the only BHC within the clinic? If that is the only BHC within the clinic, that most likely means I'm going to expect them to have maybe a little bit less of a productivity expectation of visits per day. Now, again, there's going to be talking two sides of our mouth right now.
Okay.
The reason why I'm going to expect them probably to see a little bit less number of patients per day is because, or visits per day, let's keep with the word, visits per day, is because of they are probably getting a lot of complexity within their visits. Now, I also don't want there to be a sense of like, oh, complexity means longer visits automatically and they're going to have to keep following up. That's not the point. It's more just probably what the reality of, if they have more complexity within their patient presentations, it might be harder to be more available for handoffs and just different things that go on. So I might expect a little bit lower.
And if they're the only BHC, you're looking at the reality that PCPs are going to save up.
Correct.
They're most complex. They're going to save up for things that they really need help with. Whereas if you have a plethora of BHCs, then they can have a lower threshold to maybe get prediabetes, get some other things, which might end up taking a while. But
Sarah Orton actually said this within our BHC meeting the other day about just how, even when we don't have as many BHCs on, that PCPs literally, and she's heard this, PCPs literally safeguard their patients for only the most complex to refer, right? So that's going to be a little bit more, again, I don't like using the words draining because I think there's not truth to that. And there probably is some truth to that. That's going to just create a little bit tougher of a productivity expectation, which is a tough thing to sell to administrators, right? Because it's like, well, wait a minute, what are you talking about? We've got this PCBH model. You're saying that they should see less initially, So I think there are just some contextual points there. Last contextual factor, and there's a lot more, but the last one I'll focus on so we can keep the conversation going. How long has this person been BHC within the system?
Oh.
I think that's a big thing too. If clinics, what we have found, we used to think it was a year.
We used to think it was a year, but
I don't know. What do you think it is now?
3 years.
I would say 3.
Yeah, I have that one snippet about, and I mean, 3 years is still a subjective threshold.
Right.
But I feel
what the data is kind of shaking out.
Yeah, that's true.
Yeah.
So it's not completely subjective because we got some objectivity with our data. But general sense and general feel, 3 years feels way more like a threshold than 1 year.
So these important contextual conversations that we need to continue to have within this conversation of how many visits in a day. Obviously, what percent of time the person's in clinic? How many BHCs are on with them? And then lastly, what was the last one we just said about?
How long they've been a BHC.
How long they've been a BHC. Those three, I think, are really important when we start to talk about what should visit productivity be. Now, all that being said, I would say the interesting thing about how many visits are in a day, sometimes the question doesn't make sense to us.
Okay.
Right?
I was hoping you're going to get here.
You did a really great PCBH Corner. I can't remember which one it was, but you talked about when we had the COVID vaccine and that there were so many doses that we had.
Yes.
I think for sure probably BHCs have within themselves a certain amount of visits per day that they feel that they can deliver. The truth of the matter is primary care has an infinite amount of visits that are available within a day. It just is true. I remember we've talked about this before, having a conversation with some of our BHCs during COVID, and visits were a little bit down. It's like, are we really saying that our community's not hurting right now or not struggling?
Yeah, there's like a less need.
Yeah, there's a less need. So there's an infinite amount of need within primary care arenas. So I think this becomes more of a conversation about, what is reasonable, what is the expectation, and the question oftentimes, how many visits in a day? It's like, a lot. I don't know.
As many.
Where's your mind going? Yeah.
Well, when I was getting ready for this PCBH Corner, I was like doing my hair and thinking about it. And I was like, if somebody just asked me flat out like that question, it'd be as many as you can.
Exactly.
And I know that sounds a certain way. And, we are administrators in our role. And if I want to create a system where it supports the BHC and them getting as many as they can. Like, I don't want it just to be like, okay, well, as many as you can, and then you take a BHC and you throw them out there, and then day in, day out with, like you were saying, very little reprieve, very little variety of tasks, and just as many as you can.
Yeah.
I want to create an infrastructure, which is our attempt at CHCW, create an infrastructure where people can stay fresh. So they have project time, they have administrative time, they have some type of educational duty. So they have task variety, right? So they can kind of stay fresh. So then when they are in clinic, the other thing that is really important is to make sure that we have enough other BHCs to actually meet the demand. So looking at those ratios, back to our PCBH Corner on the ratios, or maybe it was a snippet on having like about one primary care provider, about 3 primary care providers will bring you at about 1.
And again,
BHC.
depending on the setting, right? Because if you're in a community health center or if you're in a homeless clinic, it might need to be a 1-to-1 ratio or even a 1-to-2 ratio. Right. Yeah, 100%.
So if I surround, again, here's the thinking. If I can surround this BHC who has the mindset that I'm going to see as many as I can, if I could surround them with teammates, if I can surround them with easy processes to take stones out of their shoes, so having the MAs put the patient right onto your schedule, if we train them well and do a really long, it's not just about length, but we have a very inclusive onboarding so that when they walk in, they know what to do, where they feel very facile with the EMR. So, as you and I have talked about reverse engineering, that context, so that the only thing that the BHC has to do is work at the top of their license and see patients. You train them how to use the care coordination team. You train them how to use nursing. You train them how to use all these, right? And then you surround them with teammates. And then you also give them the reprieve and the task variety so that when somebody is in clinic, they can see as many as they can see.
They're in clinic, right? Like when someone's in clinic, they're in clinic.
And like you said, the need, if you actually look at it, is probably insatiable.
Well, and the thing that I loved how you said all those things, because this is also, I think, allowing directors to get different ideas for points of intervention if they have low productivity within their team. Like you said, it could be, oh, there are too many stones going on.
Yeah.
Like it's too cumbersome. There's been systems that we've worked with where it's like a handoff process took like 5 to 10 minutes. And it's like, oh my gosh.
And the BHC had to do the majority of it.
And the BHC had to do the majority of it. As you said, maybe they're in clinic 100% of the time. So they almost like hide out at places. So the productivity is going to be a little bit lower.
Or they have their administrative time either in the middle of the day or throughout the day, which, again, because I understand, I'm not trying to like throw any criticism anywhere, and some folks, their systems won't allow something else, but if you have your administrative time from 4 o'clock to 5 o'clock for the BHC, it's not like handoffs stop at that point.
Correct.
All it's going to feel like is, so my teammate's here, but I can't utilize them, which I don't want to go down to a huge rabbit hole.
It's a big point.
But protected time, it can be very key.
And what's interesting as well is that if you get all those, say you get all those stones removed, and there's always going to be stones, but say you get the majority of the stones removed, the context is ripe for this BHC to see as many patients as they can. And then say their productivity is still low, and we haven't even defined what that is, but just say whatever we define, it's low. That goes back to what you said before, is that maybe this is an incongruent value of the BHC not wanting to see as many patients as they can. And I think that's a big thing when we talk about patient or visits throughout the day. If you have someone that doesn't have the value of serving the community and really trying to see as many visits as you can, even if you remove all the stuff.
Right.
And I remember we had conversations with certain leaders, and it was just like, oh, we've removed all these different things, and the people are just like, yeah, I just don't want to see that many visits. It's like, that's really great information. This just might not be the job for you.
Yeah, there's the systemic stones in the shoes, and then maybe the individual BHC has a skill deficit. Maybe it's typing, maybe it's use of the EMR.
Well said.
Maybe it's difficulty conceptualizing trauma in a way that is a little bit more of a facile approach with the conceptualization of, maybe they're holding on to previous ideas of what better looks like. I mean, who even knows? And so in that case, like, you're addressing systemic stones, you're helping with the skill building, and then if you, like you're saying, you exhaust all of that, and the person is completely skilled, the stones are out of their shoe, then it might be a situation of value incongruence, which hopefully you're assessing during the interview process, the annual onboarding,
90-day review,
annual eval. So you're getting along the way. Okay.
Oh, can I?
Yes.
Oh,
go ahead.
So the thing that my mind goes to then, and maybe this is where your mind was going to go to as well, so let me know if it is. All that being said, the only thing I can speak of is from our team at CHCW, and then also more about my personal experience. Okay. When I work a full clinic day, probably a year or two in at CHCW, 10 was my average. 10 was what I was averaging throughout the day. Again, these are 10 meaningful encounter visits, with the vast majority of them being billable. That was 10. Now that I've been here for 10 years, or 9 years, my capacity has grown, and it's now 12 to 13 is the average number of visits per day that I'm doing. And I think when we've looked at our data, generally it seems like 9 visits a day is what seems like comes out for it. Where's your mind going?
I'm glad that, let's see, we're at minute 19.
Well, we have to keep people engaged enough, right, to actually get to the...
That's hilarious. But no, I appreciate this 20-minute conversation because that's how nuanced it is.
Yeah.
You read in the articles, the the writer, Hunter, the 28...
And then Dobmeyer.
Yes. Yeah. 2017 or 2018?
I think it's... well, it doesn't matter. The definition.
The definition,
overview, yeah.
the overview where it defines PCBH and gather. They say in it, I believe, oh my gosh, if I'm going to bring up a journal, they say that BHCs aim to see, it's either 10 to 14 or 11 to 14.
I think it's 10 to 14.
That they aim to see.
Yeah.
I think that if you just take that nugget and as administrator, you bring it back, like, you read that and it's like, okay, so
Correct.
BHC 5 days a week, 10 to 14 patient encounters. You're having shorter visits most of the time, 25, 30-minute visits. There's an 8-hour workday. That's opportunity.
You do the math, it makes
16
sense.
slots.
Yeah,
You should just be able, but it doesn't take into account, hunting worm handoff, or it doesn't take into account just, if you've ever been in clinic, all the things that can happen.
Absolutely.
And so I think that can be what's missing. It's not like they misspoke, because I think the way we're talking, I would say I aim, and I would say the majority of our OGs who've been there for 3+ years, probably even before that, aim.
Correct.
To see 10 plus. I don't know if it goes all the way up to 14. Maybe some of the OGs do. I would say 12 feels pretty good for me, but we're aiming to see. So 10 plus, that's on, but without all these contextual factors, I think it could be a very misleading number, which is why we're doing this PCBH corner. But I agree with you.
This might be too bold of a statement to say, and I'll say it though. I have yet to work with a system that actually is even tracking their number. That's usually a rare thing for people to actually track their productivity, but I've never worked with a system that is tracking their productivity and they've averaged over 10.
I've never seen it.
Never seen it. And again, this isn't to say that number between 10 to 14 is wrong, because you said it was aim to get there. In our system, it's about that. It's getting to that. And the interesting thing too is I would still say that is still not the right number. It's not about a right number, because if, like we've always talked about, we make that joke, like say we are really busy in our morning clinic. I forget, what's the most you ever seen in like a 4-hour half day?
Ooh, 10.
10, right? Okay.
Yeah, and
so here's the thing.
That was intense.
So here's the thing. You saw 10 in that morning clinic. Do you just go home in the afternoon?
No.
So that's the point, is like there is never going to be a moment where someone is going to almost like, and this almost sounds like confrontational way, I didn't mean it that way, but I'll never be boxed in to say like a specific number related to visits per day. Because my true belief is that, one, it depends on context, and it's an infinite number. That there's going to be situations and contexts and days that maybe I should see 16. Because that's what the context produced. I had the capacity to see 16. Like, I should see 16 that day. And there might be other days that just, it didn't happen that way. And all that to said, we have found that, one, through our experience at CHW, we're at a clinic more, it seems like capacity goes up. Right now, we're about 12 to 13 on average visits, and that's actually a number. That's not us guessing. That's an actual number. And our other OGs around 9 to 10 visits that are completed.
Yeah, so I guess to finally answer some questions here. In general, to break even across most systems, from what I've seen, is about 7 to 8 visits per day.
And you're talking break even revenue wise.
Yes.
Yeah.
And so we're leaning a little bit more towards 7 if the person is in a 5-day, 8-hour day clinical setting, a little bit closer to 8 if it's 4. So if you do, we're gonna do some basic math here, right?
Yeah.
So 7 times 5
35
is 35. 8 times 4
It's 32.
is 32. If you are somewhere between 32 and 35 visits, approximately, for a week, you're in a pretty decent
Well said.
situation.
Well said.
Now in our system, for our OGs, folks have been, and is it 1 year, they've been here 1+ years and they're a core BHC. We've just reached about 9 averaging.
Yeah.
No.
Oh, that's what the entire team is averaging that. That's what
even with the trainees?
No. Sorry. The cores, yeah.
The entire core.
Yeah, regardless of how many years.
Okay, so that's at 9. We are a very mature system.
Correct.
And we have our folks who are, most of them are doing In a 1.0, they're doing 70% clinical.
Correct.
So that would mean that they're responsible for covering about 28 clinical hours. Now, that doesn't take into account if they like stay a little bit late or work through the lunch hour or something. Those are like where you're like scheduled or responsible for like the 28 hours. So that would be, so in our system, you're going to get a paperwork, you're going to get a project/administrative time, and then you're going to have some type of educational duty.
Correct.
And then you're responsible for 70% of your time being direct clinical care. And with that, we actually say 4.2 is the minimum. That 0.2 actually matters.
Correct.
Because you can get a few extra visits that gives you a little bit of a pad. Because based on lots of different factors to be able to stay solvent, you're going to want a little bit of a pad there. And so that's why in our system, for you to be in good standing, it's a minimum of 4.2 for a half day, which is 8.4 for a day. However, like we said at our most recent meeting, we expect our OGs, which they do.
And that's the thing, they do.
They naturally see more. And then the other thing that, going back to what I was saying earlier, that's incumbent upon me as a director to create an environment where this can not only flourish, but it can continue.
Correct.
And you can maintain it. So if we're just out there saying, hey, 9, 9, 9, 9, with no reprieve, no teammates backing them up, no PCP champion, none of these infrastructure things, that's actually more of a recipe for burnout than necessarily just seeing too many patients. It's the lack of infrastructure and support for the BHCs.
I couldn't agree more. And as you were saying, you know, I love the 32 to 35 visits per week. However you're getting there seems to be in a good place as far as the revenue kind of goes. And, you know, I think as we begin to wrap up, this has been a really great conversation. I'm really glad that we had this conversation. Please, as directors, never make productivity, and we've talked about this regularly, never make productivity the goal. Because as we said, that's a finite thing.
That's true.
And we know there's an infinite amount of need within primary care arenas. If we focus too much on like, oh, it's 9 or whatever it is for a day, that's what we're trying to meet, I guarantee you, one, that's going to lead to more burnout, most like whatever we define as like burnout, and it just is going to miss the mark of what we're trying to do.
I just really like how you said that, because I don't think that for you or me, and I'm thinking about all of the OGs on our team, they're not motivated by 4.2.
Right.
And now I'm going to take from Sarah again.
Yeah.
Another shout out, Sarah. She always just said, when we talked about that 4.2, she just called it a guardrail. Yeah. She said, you know, that we have a basic guardrail to make sure that what I'm, you know, showing up to do.
And that's what data and metrics all should be. They should all be guardrails.
They are guardrails, because what if you could see more? And what if there was, a 24-year-old patient who finally agreed to meet with a BHC, but you've already seen 12 patients for the day? Do you say, and then that made you for the week, you're averaging your 9, well, because we have the 8.4 as the minimum, but you're averaging your 9. Do you just say, oh, I'm going to turn that down? Like, no.
It almost becomes like, if you're a BHC watching this, or if you're a director watching this, if those conversations start to come to the surface level, that's almost a good indicator to pause and be like, we're not talking about what we should be talking about right now. Because that being said right there, like whenever that becomes like, even if I saw 15 patients that day,
that's
and
16.
this one person came and they were convinced and they were brave enough to say yes, and they had a lot going on, I would hope I would still see that patient. It isn't about the number of visits I had previously. It's about that human that's there right now. It's about that infinite need. So yes, while we'll have these things, because we have to have metrics, we have to have guardrails, we have to have these things that move things, particularly related to revenue, and they're never the goal. They're never the goal.
They aren't ever the goal. And, you know, I don't want to take us down a rabbit hole when, we're at 20, was that 28? About to turn to 29 minutes. But there's what people say, and then if you've been doing this long enough, it's what they mean. And I think what you just said, like, if a BHC is saying, I'm seeing too many patients, I wonder if that's how they're feeling, right? And those are the words that they have for the context. But maybe what they're saying and what they mean is that the infrastructure isn't supporting them.
Correct.
Because if the infrastructure is supporting you, you're willing to sell out and see that 15th and 16th. But if you know you don't have paperwork, and you know you don't have a teammate, and you know that there's not somebody who's been hired who's on their way, then that 16th visit, it does become too much.
And you know, even as you said, paperwork. Say your EHR system, say it takes you 20 minutes to write a note.
Maybe, maybe you've never had training. Maybe you never had onboarding.
We joked about this regularly. It's like, could you imagine what our number of visits per day would be if, like, we didn't have to do documentation? Like, how many visits have we been doing today? It's a really interesting thing that highlights this idea of, like, again, a lot of the things and I love that you said that, when someone says, like, I'm seeing too many visits, or I'm seeing too many patients, it's like, maybe, and be curious about that, because that might be more of a statement of, I have too many things that are going on that there's too many stones right now for me to feel good about seeing this number of visits that I'm happy.
Yeah, and a lot of that has to do with hiring more BHCs. But see, this all rolls back into itself. We're saying about the guardrails and whatnot. And I'm very honest with my team that if we want to hire another person, we have to have a bare minimum, because we can't make that financial argument, so it's never going to happen. So it's this thing where the BHCs are trusting me that I will provide, or not that I will provide, I will do my best to advocate for an infrastructure that supports them and allows them not to do visits based on my terms or what CHCW, or their organization asks of them, but allows them to live out their true value, which is to take care of patients. And that was a shift for me as a new director. It was like, how can I get them to see patients? Now it's like, about that. How can I connect them to their infinite values?
And how can I remove the barriers to allow those infinite values to be realized? That was really great. And there's another video that we've done. What was it? If your system is not...
All right, we're tuning back in. I was having a little bit of a coughing fit. And what Dave was saying was that we have a really good video.
We have a good video about if your system's not ready for true integration, and I think it would be an important one to check out, because there are some conversations that oftentimes come up about, hey, my system doesn't have these stones removed, and what do I do? And we even have an old video about taking an entrepreneurial kind of mindset when you're starting a program out that might require you to have to do some things that you know that you don't want to continue to have to do as the program gets built.
Yes.
I would definitely encourage people to check out those videos as well as within this video, because I think it will provide some additional context. But I'm so grateful for this conversation. And so, did we answer the question? We actually did. We actually gave some numbers, and I think that's great. And hold lightly to those numbers, because they're never the goal, they're guardrails. Anything your mind goes to end up?
No. That was really good.
Rumble back with us if anybody has anything to rumble, or definitely let us know.
I'm sure there should probably be some rumbling, because, I think we did describe it as being complex, but even still, this cute little PCBH Corner conversation, it makes it seem neat and tidy. Like, well, yeah, if you just get 32 to 35 visits and you remove some stones in the shoes.
If your mind says the greatest takeaway is that, it should be 32 to 35 visits, we watch the corner, because that should be the main takeaway from it. Yeah.
That's true.
Yeah.
All right.
Thanks for stopping by.
Thank you so much.